Hi, I'm Alexis Olson,
I'm Lindsay Whitcomb.
and we will be addressing disparities in American Indian birth outcomes. The purpose of our presentation is to identify key disparities between American Indian and non-Hispanic white birth outcomes and recommend a suitable solution to aid in closing this gap. First, we'll run through the primary birth outcomes and how they affect a person through the life course. We will then go into the disparities associated with each outcome and suggest an intervention specific to Montana's American Indian tribal nations. We thought it appropriate to define maternal and child health and orient our health concern and intervention around it. According to Koch, maternal and child health is the professional and academic field that focuses on the determinants, mechanisms, and systems that promote and maintain the health, safety, well-being, and appropriate development of children and their families in communities and societies in order to enhance the future health and welfare of society and subsequent generations. Of course, a major health focus in maternal and child health is going to be birth outcomes. And a reflection of our existing MCH programs and our society in general is going to be the equity in birth outcomes. So as we describe, there is much progress to be made in birth outcome and general MCH equity. Before describing these inequities, we would first like to note that there are several inconsistencies with American Indian and Alaska Native health data. While birth outcome disparities are known, there is some gray area surrounding the extent of them. This is in part due to the fact that this population is very often excluded from national health data, being termed statistically insignificant due to population size. Second, we're talking about a really diverse group. There are 574 federally recognized tribes living in different geographical regions and having different cultures, governments, and societal structures. This is certainly going to influence health outcomes. So national data on American Indian and Alaska Native peoples are not going to depict the tribe and area-specific health concerns. Birth weight is one of these health concerns that cannot be visualized in national American Indian and Alaska Native health data. Some tribes experience disproportionate rates of high birth weights, and others experience disproportionate amounts of low birth weights. So while we present some available national data, we're going to hone in on Montana tribes for our program.
While the data for birth outcomes for American Indian and Alaska Native women is limited, there are data that indicate that outcomes are worse and more severe for rural women in general when compared to urban women. A recent American College of Obstetrics and Gynecology study showed significance in the difference in outcomes between the two, and while outcomes in urban Indians and rural Indians trended towards this, the lower numbers of the study were not able to reach significance.
Listed here are the primary adverse birth outcomes that are most associated with poor health and well-being over the life course. Preterm delivery is defined as a delivery occurring at less than 37 weeks gestation, and low birth weight is considered to be less than 2,500 grams, which is 5.5 pounds. As we know, there are a range of social determinants of birth outcomes. Many of these have to do with support that the mother has, as well as her age, education, occupation, and socioeconomic status. Quality of pre- and postnatal care also have an impact. The determinant that we'll be focusing on, and the one that has a huge impact on other previously mentioned determinants, is race. Specifically, we'll be targeting the great disparities between American Indian and Alaska Native birth outcomes and non-Hispanic white birth outcomes. The effects of preterm birth are far-reaching. The negative effects often last through the life course. These range from developmental, social, emotional, and learning disabilities to chronic medical conditions such as cerebral palsy, chronic lung disease, gastrointestinal problems, and hearing and vision loss. Due to statistical inconsistencies and the difficulty collecting data in the American Indian population, The extent of disparity between American Indian and non Hispanic white preterm delivery is not precisely known. Based on data obtained by the Urban Indian Health Institute, American Indian preterm births occur at least 1.4 times as often as white preterm births. And according to Medicaid data from the state of Washington, incidence of preterm births is approximately twice as high for American Indian and Alaska Native populations. So all sources of data describe preterm birth as a health disparity in birth outcomes.
Looking closely at Montana, this recent data from the March of Dimes Healthy Moms, Strong Babies report shows us that the incidence of preterm birth in the American Indian population is twice as high as the incidence of preterm birth in the white population.
Infants born at low birth weights suffer from poor health over the life course as well. Higher rates of abnormal growth and development are apparent, which result in neurodevelopmental conditions, learning disorders, and respiratory tract infections, to name a few. In Montana specifically, American Indian infants are born at low birth weights at a rate of 1.3 times that of white infants. While infant mortality is going down among American Indian and Alaska Natives, there is still a really significant disparity when compared to white infant mortality. As seen in the statistics here, both urban and rural American Indian infant mortality rates are significantly higher than white infant mortality rates. The Urban Indian Health Institute reports at 2.9 times higher than whites, while Montana's tribes experience infant mortality at a rate that is 2.7 times higher than whites. And American Indian and Alaska Natives are 60% more likely to die of preterm birth and low birth weight. So not only are they more likely to experience these birth outcomes, but they're also more likely to then die from them. When we say the term preterm birth or low birth weight or any other birth outcome, we often think of the infant, but of course the birth experience in general has huge health implications for the mother. American Indian and Alaska Native women are 2.3 times more likely to die from pregnancy-related issues than non-Hispanic white women. So why is this? Well, you can't cure a lifetime of ills in 9 months of pregnancy. Systemic issues accumulate and give rise to higher rates of poverty, physical and sexual violence, and adverse childhood experiences in American Indian women. These in turn poorly impact physical health and subsequent birth outcomes. The resulting adverse birth outcomes then give rise to adult diseases like those listed here. So high blood pressure, type 2 diabetes, coronary heart disease, cancer, and obesity all have fetal origins that are first impacted by maternal health. So we begin to see a really vicious cycle here. Let's continue to put birth outcomes in relation to the entire life course. The life course concept provides a view of the cumulative impact of social and environmental factors on physical health over the lifespan. While the figure to the left displays disparities through the life course between white and African American women, we can use the same exact concept and apply it to the disparity between white and American Indian and Alaska Native women. So in the figure, there are many more arrows representing risk factors placed on the lifespan of American Indian women. These arrows represent risk factors to health like generational trauma, structural and individual racism, and the previously mentioned increased risk of poverty, violence, and ACEs. We see that pregnancy is a short period of time in relation to the life course, but the graph also shows that it's a critical and sensitive time, with American Indian women's health potential declining much more severely than white women's. So we should be looking for protective factors we can introduce or support in the life of American Indian women that are within the scope of maternal and child health professionals.
Shifting gears a bit, when we look at Montana specific data regarding the initiation and utilization of prenatal care, we can clearly spot statistically significant differences at both measures in respect to American Indian prenatal care. This has the potential to be a huge source for negative outcomes in the infant and maternal birthing experience for American Indians. Multiple factors may inform the American Indian mother in when or whether to seek prenatal care, but there is no clinical question about the importance of optimizing prenatal care and the ultimate benefits seen in the outcomes for both the mother and the infant. According to Krieger's eco-social framework, health behaviors must be viewed within the context of the social and physical environment in which the constraints are placed on the choices available to healthy behaviors. When deciding on an approach, the structure of the intervention may take the form of either targeting the social and physical environment to address American Indian or Alaska Native birth outcome disparities like structural racism, transportation obstacles, or chronic stress, or it could target maternal environments and choices such as alcohol, tobacco, or drug use, or interpersonal relationships. While either approach may be successful, for design evaluation purposes, it may be useful to narrow the scope of the intervention somewhat in order to ascertain with more reliability the most beneficial aspects of the intervention. Here are some statistics for recent birth and wellness information for the state of Montana, again from the March of Dimes Healthy Moms, Strong Babies campaign. Notable to our program for these general statistics are that 41,000 women in Montana live in a maternity care desert. And as so, it stands to reason that impactful programs would address the obstacles to care that this would create. The geography and population centers in Montana offer a few initial observations about the disconnect between American Indians and optimizing healthcare. In the Northwest, 90% of American Indian and Alaska Native births do not occur at an Indian Health Service hospital. American Indians have a complicated history with IHS, one that could do well to have some remediation. While IHS care facilities are located near Indian populations and reservations, most are not equipped to handle labor and delivery services in Montana. And the expanse of land in Montana means that even the nearest IHS medical clinic may be insurmountably far to get to for a pregnant woman without transportation. Additionally, while there are certainly American Indian communities and persons in every pocket of Montana, as we see on the next slide, the major medical centers are logically located near the overall population bases, which is a very different picture than the tribal reservation map. Some pertinent background information is that there are 12 recognized Indian tribal nations in Montana, with 7 established reservations in the state. A recent count puts the population of individuals with American Indian heritage in Montana at 78,000 people. As you can see, with the exception of the Flathead Reservation encompassing parts of Missoula County, most reservation land is not near the population bases in Montana. And while a 2006 tribal enrollment survey in Montana estimated that 30 to 50% of American Indians in Montana do not live on their enrolled reservation land, this is not to presume that they do not live on a reservation at all, as some American Indians are enrolled in multiple tribes, nor does this preconclude that the remaining American Indians live predominantly in population centers. Thus, it is reasonable to conclude that the majority of American Indian population in Montana live as rural Indians. While we are working with limited data regarding the health and birthing outcomes for American Indian peoples, the data that we do have indicate that rural Indians face even greater health disparities when compared to urban Indians, as previously discussed. Therefore, the structure of our program intervention will target the modalities that have the highest likelihood to impact obstacles of care and risk factors for rural Indians. The basis for our intervention could essentially be generalized under the label of home health visits meet cultural competency. We propose a program which incorporates the traditional model of home health nurse visits and tailors the experience to incorporate Native American family values, traditions, communication styles, and even language. The core operations of the program are to employ and train a variety of healthcare professionals to provide home visits to pregnant American Indians with the objective to maximize prenatal care for the infant and reduce morbidity and mortality outcomes for the mother. Home health visits by nurses are social programs that often pay for themselves within the short term. The tribal home health visit can incorporate prenatal care to improve compliance with adequate prenatal care standards and help patients overcome geographical and logistical transportation issues for checkups not requiring complicated technological needs such as advanced ultrasound equipment. As part of the main objective of the program is to provide culturally relevant healthcare promotion informed by locally relevant tribal heritage and understanding. The selection and hiring of program providers will prioritize Montana based Native Americans with enrollment in local tribes. We believe that tribal members can deliver the most culturally appropriate care to other American Indians. Generally, federal law prohibits employers from making employment decisions based on a person's race, color, religion, sex, and national origin, including membership in a Native American tribe, based on Title VII of the Civil Rights Act of 1964. However, the Bureau of Indian Affairs has been afforded the authority by Congress to allow for prioritizing of Native American applicants when hiring for the Bureau of Indian Affairs or Indian Health Services positions. We believe the program may be received more broadly and potentially be more efficacious if implemented by a qualified trained tribal member and feel it is appropriate to utilize this authority to prioritize the placement of Native Americans for these positions. Prenatal visits would be conducted by physician's assistants, RNs, nurse practitioners, and eventually lactation consultants. We would attempt to maintain periodic in clinic visits by the patient as required by the intensity of the visit. Pelvic exams and exams requiring high level equipment would need to be conducted in clinic. Care providers would travel with blood sugar testing equipment, urinalysis and blood draw sample supplies and their associated biohazard or transport equipment, and general prenatal care supplies, including weight scales, measuring tape, and stethoscopes. Cost containment would be helped by not dispatching higher level providers than necessary, but as the success of the program depends on the quality of care being able to be provided within the home, we would not include LPNs to provide care for patients as they generally require more direct oversight from physicians. Efforts would be made to create continuity of care in deploying the same provider for individual patients unless otherwise unavoidable. Providers would need to maintain a valid driver's license and would be reimbursed per mile for miles driven in their personal vehicle. Program enrollment beginning early in pregnancy and culminating after the infant reaches 6 months of age. Our program will recruit participants via word of mouth, tribal community centers, family planning clinics, high schools, and partnerships with IHS obstetrician and family practice clinics, as well as non-tribal medical practices. Similar to the general population of those eligible for social services, many Native women living in low income and poverty conditions are enrolled in some social service programs such as Medicaid, WIC, SNAP, and SNAP, but utilization of these and other local services is often not fully realized, and some are not enrolled in any for various reasons, including misunderstanding of services offered, or misinformation, or lack of understanding about their own eligibility, or difficulty in completing enrollment processes due to bureaucratic obstacles. For these reasons, as part of their purview under the general overview of eligibility, I'm sorry, for these reasons, as part of their purview under the program, home visit professionals will be trained in identifying potential poverty related issues such as housing, food access, and similar. The general the general overview of eligibility for various programs, and will recommend and provide contact information for the programs for which the client may be eligible and provide this information to said social program liaison for follow up as well. Other identified risk factors, such as substance use or abuse referrals, are relevant to the health of the pregnancy and the baby and will be included in surveillance and referral. Focusing again locally on Montana, we see that in recent years, infants of American Indian heritage make up an average of 12.6% of the births in the state. The Montana Department of Health and Human Services has shown a range of about 11,500 to 12,500 live births per year over the last 10 years, and that number is trending downwards. That puts the number of American Indian births at about 1,500 per year. Measuring maternal and infant mortality in populations can create unique issues. If we consider that American Indian births are roughly 12% of total births in Montana, and live births are averaging at about 12,000 per year, a study period of 5 years should give us a pool of about 7,000 total American Indian births from which we could monitor and evaluate both infant and maternal outcomes and data. A 3-year period would give us just over 4,000. While both of these numbers seem like a good chunk of numbers for appropriate for data evaluation, we must consider that certainly not all American Indians will be enrolled in the intervention. So we hope to be able to fund this program for an initial study period of 5 years. Our baseline data would include general health data relevant to prenatal visits, substance use and mental health history, social support information, social welfare and or insurance program enrollment. As a community-based participatory research project, the program would be overseen by Indian Health Services, tribal departments, and community leadership and stakeholders to better identify and address tribe-specific maternal and child health concerns and obtain continuous feedback on the program. Our intervention would measure both quantitative and qualitative data sets. Summative evaluations would benefit from focus groups involving mothers from differing tribes who were previously enrolled in the program. Looking ahead, given the limited existing data for American Indians, the unique landscape of tribal nations in Montana represents a significant opportunity to collect relevant data for future studies and programs. All data collection and surveying should be done in a way that provides important baseline and outcome data to build upon in the future while maintaining respect for the privacy of American Indians and the individuality between the tribes. As the American Indian Health Commission for Washington State has noted, program evaluation is difficult in small populations such as tribes. When programs have been evaluated in larger populations and found to be effective, it does not necessarily mean that they will also be effective in the tribal context. Adaptations may be needed to make the program more culturally appropriate and or more workable in a small scale or in a rural context. Tribes each have their own language and their own significant practices. Interventions should be designed to be delivered at the local level wherever possible. Tribes should be encouraged to suggest interventions that would work best for their members. A one-size-fits-all approach creates barriers to participation by tribes and by individuals who need their services. Future enhancement of this program could also include attempts to build support networks amongst new mothers and tribal elders. Assimilation attempts throughout the 19th and 20th centuries removed American Indians from homes and created a generational gap in American Indian heritage and practices, and creating new connections between older and younger American Indians could possibly help bridge that gap. Additional expansions of the program could lengthen the duration of the program itself to facilitate parenting and pairing it with milestone and child wellness visits, or also could train providers to assess for postpartum depression and more. We need not reinvent the wheel. Future programs should look to duplicate or improve upon successes that have already been achieved in similar areas and populations. First Steps is the Washington State program to carry out the Maternity Care Access Act, enacted first in 1989 to improve birth outcomes through increased access to prenatal care and support services for women below 185% of the federal poverty level. First Steps includes Medicaid, as well as maternal support services and infant case management. For core and preventative health services for pregnant and postnatal women, it also included professional observation, assessment, education, intervention, and counseling services that are provided by an interdisciplinary team and consisted at a minimum of a community health nurse, a nutritionist, and a behavioral health specialist. The program had a really important initial impact to improve the low birth weight outcomes, but the improvement was lost in the American Indian population after the first evaluation time subset. Another program that has seen success is the Parent Child Assistance Program. It provides advocacy services annually to high risk substance abusing pregnant and parenting women on the Spokane Reservation and other nearby counties. Thank you for listening to our ideas, and we hope that someday we can come up with a good solution to help American Indian women and children and babies in Montana.
Thank you so much.